missing one, or if this is yours, please feel free to come up in here so we can give this back to you. All right. Without further ado, I would like to present our next two presenters. So we have Dr. Justin Blackburn and Dr. Heather Taylor. Dr. Justin Blackburn is an associate professor in the Department of Health Policy and Management and serves as director of the PhD program in Health Policy and Management. He is also the associate scientific director of data and evaluation for Well-Informed by Science and Evidence Indiana and affiliated scientist with Region State Institute with the IU Center for Aging Research. He earned an MPH in epidemiology from the University of Kentucky College of Public Health and a PhD in epidemiology from the University of Alabama in Birmingham School of Public Health. Dr. Blackburn's research primarily involves leveraging large administrative data sets to evaluate public health policy and outcomes at the state, local, and the national level. Dr. Heather Taylor is an assistant professor at the Indiana University Richard M. Fairbanks School of Public Health in the Department of Health Policy and Management. She is a licensed dental hygienist and health services researcher who focuses on oral health, mental health, and population health informatics in low-income, underserved populations. In 2022, she received Indiana University's Distinguished PhD Dissertation Award for her work on dental care using and use among Indiana Medicaid enrolled adults. So without further ado, I present to you Dr. Justin Blackburn and Dr. Heather Taylor. Thank you.
We're going to have to act them out like we. There we go. Great. And so this is there. Perfect. All right. Good afternoon. Really excited and honored to speak to you this afternoon about this study that Dr. Taylor and I did in partnership with the Department of Mental Health and Addiction. And I think there's some interesting results here and really some consequences about mental health in a way that we don't always think about. And so just a few sort of context. I think this is pretty familiar to this group, but mental illness really has a broader effect on health. Chronic diseases can be worse. It can affect a lot of the population. So almost 20% may have some mental illness. And it's overrepresented in populations that are, vulnerable and have high consequences. So like justice involvement, homelessness, and it also can be a factor with unemployment. And so these are kind of important context and outcomes as we look through this analysis that we kept in mind. So I wanted to mention that this analysis that we did was really as part of the Behavioral Health Commission. They asked us to do this. This Behavioral Health Commission, as you probably know, was set up to discuss and make recommendations about mental health and behavioral health for all Indiana residents. And so one of the statutes for this commission was to establish the cost of untreated mental illness in Indiana. And so that's where we came in to try to answer that question for the commission. And I also want to mention that this partnership from the Behavioral Health Commission asked why is Indiana so well-being informed science and evidence in Indiana is a partnership with the Indiana CTSI. So not just IU, but Purdue and Notre Dame and researchers around the state involved in this partnership. And so I think it's important to kind of start with just this question and thinking about it, because we don't always think about how the economic burden of a disease or of particularly mental illnesses. And so there's a few key concepts that we have to think about when we took this on. And one was sort of how do we define mental illness more specifically? And then what are the kind of the costs that are most important, or the most important costs that we can actually measure? And then how do we actually go about establishing these costs, and how do we establish them that are attributable to mental illness? And so starting with that first question, how do we define it? And so there's a very broad definition. And for our analysis, we really operationalized it based on some of the more common definitions. So we had any mental illness, and these are things like anxiety and depression, including bulimia and anorexia and these types of conditions. And then as a subset, there's also what's known as serious mental illness, and these are a little bit more debilitating. So schizophrenia, bipolar, and major depressive disorder. And then more specifically, we can actually look down and see what these codes are and how they're established in medical records. And we really worked with Department of Mental Health and Addiction on defining this population and how we actually estimated it. And so when we get to the analysis, I don't want to jump too far ahead, but this is the basis for what we're calling mental illness. But the way we actually estimated and wasn't always a diagnosis base. We used symptoms, scales, and things like that. So it's important to keep this in mind, but know that we weren't strictly related to a medical record diagnosis in a lot of our analyses. So Dr. Taylor's going to get through the hard methods and parts, and then I'll come back and take over.
Thank you. All right, thank you, Dr. Blackburn. All right, so now that we have figured out how we would define mental illness and serious mental illness, now we can start approaching the question of what costs are actually associated with mental illness. And we knew broadly that these costs are attributable, are effective to the individual, to families, and to communities as a whole. But we really needed to identify specific costs so that we could obviously tabulate them. So what we did is, of course, like most researchers do, we turned to the literature. We looked to see what has been done on this topic already. And we conducted a rapid scoping review and discovered that no one has actually published on the economic burden of all mental illnesses, at least in the United States. In fact, if you look over to the left of the screen, top left, the government had a report done in 2019 that highlighted there was limited and sparse amount of evidence published on healthcare costs associated with untreated mental and behavioral health conditions. So nonetheless, we still kept digging, and we were able to find economic analyses of specific mental illnesses. So for instance, bipolar disorder or schizophrenia. So what we did is we examined these articles on these specific mental illnesses to determine what economic costs are they considering as they tabulate the economic burden of these specific illnesses. And then we use those as a framework or a model to build our work from. So consistently, when we looked across this literature, which again was limited, we did find out that for the most part, economic costs are sort of conceptualized into two buckets: direct costs and indirect cost. Your direct costs are disease-related expenditures. So this can include direct healthcare costs and direct non-healthcare costs. And then separately, we need to think about indirect costs. These are costs that are related to resources lost to the illness. And so once we thought about conceptualizing costs in these buckets, then we were able to drill down. So when I'm talking about direct healthcare costs, I'm talking about all expenditures that occur in a healthcare setting. So they're your inpatient expenditures, outpatient, emergency department, pharmacy expenditures, and anything else that occurs in the healthcare environment. When I'm talking about direct non-healthcare cost, well, these are things such as incarceration costs related to those incurred in prison or a juvenile center or jail, and then also homeless shelter costs. And we had to think about homeless shelters in a little bit different way, because the costs incurred by individuals who are chronically homeless, who may need the homeless shelter for a year at a time or so, are far greater than, let's say, homeless individuals who come in and out of those shelters for a brief amount of time. Indirect costs also include things like unemployment, productivity loss, premature mortality, and caregiving cost. So our productivity loss, we wanted to consider absenteeism, how many missed days at work are happening because of untreated mental illness. And then presenteeism, maybe they are coming to work, but they're not as productive as they typically would be if their mental illness was being appropriately treated. Premature mortality, this encompasses suicide and also all-cause mortality. And then finally, we can't forget the costs that are incurred on our caregivers who largely take care of this population. So they have excess healthcare costs, right? Because they're caring for someone who has a mental illness, they themselves are not perhaps able to seek the healthcare that they need as often or as frequent as they may need to. And so they may have excess healthcare costs above and beyond what typically they would have. And also they have productivity losses as they care for these individuals. So we also need to consider those costs incurred in society to them. What I did just now is I walked through all those costs, but here I've listed them all out for you. So you can see that we have a very extensive itemized list of all the costs that we would have to tabulate for individuals who have mental illness, but really untreated mental illness. And beyond that, we really needed to tabulate all these costs for each of these groups of people. So we had to tabulate the costs for individuals who have serious mental illness, tabulate all these costs again for individuals who have other mental illness outside of serious, and then tabulate all these costs for those who fall within ages of 5 to 17 children. And the reason we had to do this is because the prevalence and the risk of these outcomes is very different depending on what bucket or group you fall into, right? So for instance, the risk of incarceration for someone who has serious mental illness is much higher than the risk of incarceration for somebody who has, let's say, an anxiety disorder. And so we needed to take into consideration as we're tabulating these costs, those nuances in prevalence and risk by the group that they fall into. All right, so to begin, now that we knew what costs we had to do, now we can begin actually doing some of our calculations. And we needed to determine how we would estimate all of those costs I just showed you on the previous slide at the societal level. And how do we make sure those costs are actually attributable to the untreated portion of the society that has mental illness? So ultimately, we came up with two different approaches, one for summing costs for direct healthcare costs, and the other approach for summing costs that fall under direct non-healthcare costs or indirect costs. Now, it's important to note that we use state prevalence data that I'll get to in a second. And that data underpinned both approaches. We use state prevalence data for both approaches. But again, I'm going to walk through each of these approaches in detail. So let's first talk about the state prevalence data that underpinned both approaches as we tabulated cost. So what you're looking at right here is data from SAMHSA. This is their 2019 National Survey on Drug Use and Health. This survey provides state-specific data, and they actually have data on the prevalence of any mental illness and the prevalence of any serious mental illness in the state of Indiana in 2019. And so as you can see from this data in Indiana, about 22.6% of Hoosiers adults have a mental illness, and nearly 6% have a serious mental illness. Importantly, this survey also provides information on the proportion of those with mental illness who, quote, needed mental health treatment, but didn't receive it in the previous 12 months. And so this data, this prevalence data, this proportion became what we would continue to use throughout this approach as the proportion of individuals who are actually untreated with mental illness. And overall, when we take all these numbers together, we calculated out that approximately 6% of Indiana's population of adults has untreated mental illness. 3% have untreated serious mental illness. Now, for children, we used a similar but different survey data. We got our prevalence data from the National Survey on Children's Health. Similar to the National Survey on Drug Use and Health, they have a national interview survey. In this case, they ask parents to report if their child has ever been diagnosed with an emotional, developmental, or behavioral problem. And then they also ask separately whether or not their child received treatment or counseling for their mental health from a mental health professional. So based on this data, we found out that 25.9% of children in Indiana have a mental illness, of which 4.1% did not receive treatment or counseling from a behavioral health specialist or mental health specialist in the previous year. And again, that percentage became our basis for untreated mental illness within children. Okay, so I've walked through just sort of the prevalence data and where we got that data and how that underpins our two approaches. Now I'm going to dive in deep into both approaches that were taken as we calculated cost or tabulated cost. So the first approach we took was related to estimating direct healthcare cost. So to estimate this, we ended up taking a very common sort of health services approach to this question, and we leveraged Indiana Medicaid claims data. We basically took Indiana Medicaid claims data and we identified enrollees between the ages of 5 and 64 who had a mental illness. And we defined these individuals as having a mental illness is when we looked through the claims data, did they have a primary diagnosis code that was related to a mental illness? Or did they have a mental health procedure code that was related to mental illness? Or did they have a pharmaceutical medication commonly prescribed to treat mental illness within their claims data? And that gave us sort of an initial starting point to find what would begin our cohort. So from that group, we identified enrollees who met our definition of having a mental illness. They had a diagnosis code or procedure code or a pharmaceutical. And we wanted to identify individuals who had one of these signals in the second year of their enrollment. So let me back up and say, this group that we pulled data from were individuals who were continuously enrolled for 24 months, 2 years, between the times of 2018 and 2019. So what we wanted to find was not in their first year of enrollment, not in the first 12 months, but in the second 12 months, they have this signal that they have a diagnosis of mental illness, either again by a procedure code or a diagnosis code or from a pharmaceutical commonly prescribed for mental illness. So to clarify, if the individual or the enrollee was receiving mental health treatment or services in their first year of enrollment, if we saw that signal in that first year, they were not included in our study. Okay, we really wanted to see individuals who had no signal that first year enrollment, but then had a signal for mental illness in the second year. Then we matched those individuals who had no mental illness in year 1, but mental illness in year 2, to individuals who had no mental illness whatsoever, no signal for that in the claims in both years 1 and 2. And we matched them on sex, age, race, and county of residence. Excuse me. So as part of our research design and approach, what we did is we assumed that the individuals who received treatment for mental illness in their second year were likely experiencing aspects of their illness before it was diagnosed in year 1, prior to actually getting the diagnosis and prior to actually getting a receipt for the mental illness. They were experiencing aspects of their illness prior to that. And so, thus, the difference in cost in pre-treatment versus post-treatment represent the cost attributable to their mental illness for a time being untreated or undertreated. So we totaled healthcare expenditures, including all those things we talked about earlier, inpatient costs, outpatient costs, pharmacy costs, in the year prior to them getting mental illness treatment. And then again, we totaled those costs in the year 2, where they were receiving some sort of diagnosis or treatment. And then we subtracted year 2 from year 1. We repeated those steps for our matched group who had no mental illness in year 2 and 1. And then we compared those differences in costs between those two groups as our estimate of the cost of untreated mental illness. Now, it's important to note, and this was a limitation in our study, we only had access to Medicaid claims data. We know that people who have mental illness also have private paying insurance. And so we needed a way to take what we learned from Medicaid claims data and extrapolate it out to what we would assume private paying consumers would have. And what we did is we found an article in the literature, this has been done before, where you can extrapolate findings associated with cost to those who are privately insured by taking Medicaid costs and multiplying that by a conversion factor of 1.7. And we applied that assumption in our study. We took the cost that we had tabulated within the Medicaid enrolled group and then multiplied that by 1.7 and came up with what we would estimate would be the cost incurred by private payers. Then we used the assumption of our statewide prevalence that said, mental illness, untreated mental illness was 3% in the serious mental illness group, 6% in the general population. We multiplied that proportion by those costs so that we could get down to the true untreated mental illness proportion in our society. And that got us here. That got us a little portion of this question of all these costs. Now we've been able to do our best to estimate what the direct healthcare costs of untreated mental illness would be for these groups here. Now we need a separate approach for the rest of this list, and that would be our direct non-healthcare costs and indirect costs. Excuse me. Our second approach for estimating these costs required a series of equations for each cost incurring outcome that we had previously identified. So the first thing we have to do is actually determine the excess risk of the individual experiencing the outcome given that they have this mental illness. And so because not all individuals with a mental illness experience an outcome due to their illness, we had to take into the account the excess risk of the individual experiencing the outcome attributable to that mental illness. So this was calculated by subtracting the risk of the outcome occurring among the general population from the risk of the outcome occurring in the group that has mental illness. And this gives us our actual excess risk. Next, we multiplied that excess risk by the total population in Indiana known to have a mental illness with the expected proportion to be known to have untreated or undertreated mental illness. We made the assumption in our study that the untreated proportion of those with mental illness in each outcome is proportional to the untreated proportion in the general population that we had identified from state prevalence data. Justin, can I have that water bottle? Sorry, excuse me for a second. Thank you. All right. So when we multiplied all these things together, we're now able to start getting some cost. We multiply the number of Hoosiers with the outcome. We can get this information from government data sources, the literature, find out who is experiencing this outcome, multiply by the number of Hoosiers with the outcome attributable to mental illness, times the cost associated with each direct or indirect cost outcome. So for example, in the case of an individual who has mental illness and is incarcerated, we take the number of Hoosiers who have mental illness and are incarcerated times the cost per day for a prison resident in Indiana times the average length of stay that person would have in prison to reach the costs incurred through prison incarceration that are actually attributable to mental illness. And we repeated these series of calculations for this entire list and then repeated it for each group that an individual may have fell into. And so finally, when we actually pull all of this data together, which we've simplified for you today, we end up with a total cost of untreated mental illness in Indiana being approximately $4.2 billion a year. Now, this is a significant number. It represents about 1.2% of Indiana's gross domestic product. I'm so sorry. This number actually exceeds corn sales in Indiana, which is actually the state's leading agricultural commodity. And if we were to actually extrapolate this out to the average wage of Hoosiers in Indiana, this amount is comparable to about 100,000 jobs. So for Indiana, which is a state that works, that's a significant number of Hoosiers that could potentially have employment if we were perhaps not spending money on just covering the cost of untreated mental illness. To put this in more of a personal perspective, spread across all residents in Indiana, this is a loss of about $600 annually per state resident, or nearly $1,600 per state family. The largest cost attributable to untreated mental illness was found to be premature mortality, which was estimated to be $1.4 billion annually. So this is the summary of our findings. I'm going to turn it back over to Justin, and he's going to talk about some of the limitations of our work.
All right, thanks. So I think it's important to note, right, you get this question and it seems like an intractable problem, like how do we start breaking all the costs? And I think Dr. Taylor walked through a lot of that and pretty quick, but yeah, there's a lot of assumptions that we made and we know that and we're fully transparent about it. And what we did here was tried to make an attempt to really document all those assumptions so that we could defend it. And yeah, maybe you say, okay, well, that's, you forgot an outcome, and we freely admit there's things that we didn't have access to, like we don't include Medicare costs. Now you could argue that, right, that's a federal cost, but it's part of the overall economic burden. We don't have like things that may be sort of trivial, but maybe not, we don't know, like the judicial and legal costs associated with incarceration. We're really just calculating, as was the example, the price to incarcerate somebody per day. And so there's things that we missed, we know. We also might have overestimated things too, and we freely admit that. But what I think we did was we're very meticulous about finding the evidence-backed estimates and costs and being very transparent about it. And we have calculations that we can show to try to get at this problem, because nobody's ever thought about it this way in this comprehensive manner. And so I think it was a worthwhile exercise despite some of these limitations. And so I think I've covered, and the other thing I would say is, so some of the outcomes, but estimating the prevalence of mental illness and then the prevalence of untreated mental illness, we freely admit, right, that's not a perfect measure. It is the best that is available to us. And so we tried to do that based on national surveys and national instruments that are symptom-based. But at the end of the day, self-reported is sometimes biased in responses. So I would say the implications of this, this is a big number, right? This was a very large cost. And I think the implications were bore out in the Indiana Behavioral Health Commission's recommendations. They made several recommendations on building comprehensive crisis response centers and certified community behavioral health clinic models, changing of that and various things. And so we saw this play out in the legislative session with Senate Bill 1 and how that tried to address some of these things. And so I think it was important context to put this from an economic perspective, because this isn't right. We know the implications on families that could be very significant. We know the implications on a personal level in many cases, but putting it in perspective of, okay, we can't afford not to do anything because this money is just vacuumed out of the economy. Now it makes a business case. It makes a case for action economically, as well as sort of health-wise and mental health-wise. And I think there's a lot of potential future work. This is really just the beginning. And as I said, there's limitations, and I think we can improve upon some of our models, but I also think there's a lot of future work in terms of how can we determine, do investments work, and how can we track this over time to see if access can reduce some of these costs and how that might play. So there's a lot to do here, as with all sort of mental health work, that there's a lot to do, but it's exciting that we've come as far as we have, I think. And so I mentioned too, this is a large team, including some of our state colleagues and colleagues from Bloomington and IUPUI, and so it wasn't just the two of us that did this analysis. It took a whole team of folks vetting and going over the calculations. So thanks to those. And so I think do we have a little bit of time for questions, or are we kind of right at time? Okay, so happy if you have any questions or thoughts, happy to take those. Refer them to Dr. Taylor if I can't answer.
Hi, I have a question for Dr. Heather. So I'm doing a PhD in epidemiology, but I took a health policy course at the O'Neill School of Public and Environmental Affairs. And I noticed that when they do research with claims data, sometimes you have an ID. You can have one person multiple times, right? And when I was discussing with some colleagues in the epidemiology department about my interest of using these claims data for epidemiology, some of them claim that it will be problematic because how would I account for these? Like, how would I make sure that that my unit of measure is the person and not the multiple times this person uses a service? So I'm curious I'm still in training, so I will be very interested in understanding how do you account for that in your research? I would like to know if for my dissertation I could use like claims data or not. Like, is that actually that you can do, or is that like just a general limitation of working with claims data?
I'm happy to try to think. So I'm a recovering epidemiologist now, doing claims data work a lot. And so we do encounter this problem. The good thing about claims data is that it's a record of a transaction that occurred and money exchanged hands and it was paid or a service was provided. So you can feel pretty confident that that happened. You do have to be careful on that aspect. You always have to know the unit of measurement, because you can inflate and think, oh, well, this many people or this many services were delivered, when really it is multiple services provided in one encounter. And so I think what I would tell you generally is proceed with caution. Have somebody that can advise you on that's worked with claims data, but certainly you can get to those types of answers to questions where prevalence, or overall costs. And actually costs makes it a little bit easier because it's just addition. You're not having to deduplicate as much. And so what we tried to do there was estimate the cost of disease based on an aggregate number of services used in an entire year. So it actually made things a lot easier. But yes, you do have to be careful, because there's also the adjudication process of, oh, this was paid for, or this one was denied, and doing that. So what I would just tell you generally is make sure there is a learning curve, and make sure you have somebody advising you on how to work with those data. It's taken me 10 years and I still don't know everything there is to know about claims. So. Right, thank you. Well, as if anybody ever has any questions, you can find us, and happy to, engage in any question and answer over email. But thank you for having us and letting us present our work.
Thank you very much, Dr. Justin Blackburn and Dr. Heather Taylor, for that excellent presentation. A lot of good citations. All right. So next up, we will be having a presentation from Dr. McKay and Adam McFatridge. Dr. McKay is a seasoned law enforcement professional with a wealth of experience in various investigative capacities. He received his PhD from Purdue University and spent 27 years with the Indiana State Police, serving in a number of different roles over the years. During his time with the state police, he worked as a district detective, investigative squad sergeant in the methamphetamine suppression section, and more. He has processed more than 300 clandestine laboratories scenes and served as a district investigations commander and North Operation Commander for the Drug Enforcement Section. In March of 2022, Dr. McKay joined the Indiana High Intensity Drug Trafficking Area Program, where he now serves as coordinator for the performance management process and joint training programs. Adam McFatridge is a highly experienced criminal analyst and military veteran. He received his MA degree from Valparaiso University and has served in the Indiana National Guard for 26 years. For the past 16 years, he has worked as a criminal analyst with the Indiana High Intensity Drug Trafficking Area Program, where he is responsible for writing and editing the annual threat assessment and other strategic products, as well as conducting officer debriefings and providing tactical support. He has also served as human intelligence collector for 18 years in this capacity. He has conducted interrogations, source operations, and provided management support of human intelligence. With his expertise in criminal analysis and human intelligence and collections, Mr. McFatridge has been a champion to the Indiana HITDA program and to law enforcement agencies in the region. I happily present to you our next presenters. Thank you.
This might be a good time to freshen up your coffee, clear your emails, whatever. I'm Don, Adam. We'll be real casual, happy to take your questions, all that good stuff. I think you have the clicker, Adam. So just a quick down and dirty about what HIDA is, because some of you all may not be familiar with it. HIDA is High Intensity Drug Trafficking Area. We are not an agency, we're a program. Its purpose, disrupt the market for illegal drugs by dismantling and disrupting drug trafficking, money laundering organizations, and improve the efficiency of initiatives doing that side of work. We are very county specific, created by Congress, ONDCP, copy available upon request, all that good stuff. For what it's worth, there's 33 HIDAs, all 50 states, all territories, and District of Columbia. Indiana specifically, we have 7 HIDA counties scattered about the state. Again, those are county designations. There isn't an actual approval process. And with that comes being part of the HIDA program, resources through ONDCP. Every year, each HIDA has to complete a threat assessment. And we're going to give you a little bit of ours. This program was put together way in advance. We're finishing it up right now. You all get a copy if you want it. It'll be published on June 15th. It contains or consists of field interviews. Special thanks to Sierra Health for helping us on our survey design. And we'll let Adam start talking.
So first one of the first questions from the survey is the greatest threat. We rank all the drugs. This year, we just had them rank the top 3. And then we did a weighted So we listed about 7 drugs. I think we had 7 categories. And then we just ranked the top 3. So those are the ones we're going to talk about today.
One thing, and statisticians out there are going to want to know, how did you come up with your top 3?
That was me.
How'd you come up with your top 3? We could say we guessed, but we didn't. We used weighted rank sums because they were asked to pick your top 3. So we did weighted rank sums. Anybody wants to get with us and say that's the stupidest thing I ever heard of in my life? Why in the hell did you do that? Feel free to get with us and maybe we'll change it next year.
So kind of the overarching theme with the 3 drugs is availability and mass manufacturing. So China brings in these precursors for meth and fentanyl. They get manufactured in these super labs in Mexico. So they're cheaper and cheaper. They're easy to manufacture. And then they just flood our streets. We'll get into some of the details, but all of that is backed up with seizure data and then a lot of our survey data. There's the greatest threat. So availability data, we just ask them availability of fentanyl. 65% of law enforcement respondents said it was high. And then 71% said it has increased over the past year, which was already high. We also asked about demand. Demand for fentanyl is high. When we get into heroin, we'll get into this a little more, but that's kind of tricky because, you know, whether they're talking about heroin or fentanyl, it's hard to know. Some of our CSs are just saying there's fentanyl.
Cooperating sources.
Yes, confidential sources. They're saying everything, or fentanyl is mixed in all heroin. So all heroin that we're seeing on the streets, there's at least fentanyl mixed in, or it's just pure fentanyl. So whether here they're talking about demand for actual fentanyl or demand for heroin, and they don't really know what's in it when they're using it. So that's where we kind of use our some of our data and overdose data to try to make sense of that. So as you can see here, seizure, fentanyl seizure is going way up. Is that all opioids?
Yeah, our deaths are all opioids and death any drug is the green line.
So
All data except death data is ours, so it's all internal data. First to see it out of the office, but yes, then MPH is the source for the death data.
So the dosage units total is when we see grams, kilograms, we convert it to dosage units. Pill is 1 dosage unit. So that's another big story with the fentanyl. It's mixed in everything. There was a slide earlier that showed broke down all the overdoses according to drug. So you can see cocaine, meth, all of those just slightly increasing in deaths because now you got fentanyl mixed into those drugs as well. They press them into pills. So a lot of, like I said, a lot of people don't exactly know what they're taking, whether they think it's heroin or fentanyl. Some of the pills that they're pressing now look like oxycodone or Oxycontin, Adderall, Xanax. They look like pills that there's been cases of college students. They think they're just taking an Adderall, seemingly harmless, and then they end up dead. So we see, this is an interpretation of the data, but we see hospitalizations for opioids going down as the deaths go up because all these drugs are so much more potent now with fentanyl mixed in them. So normally you would take a pill and or one of these other drugs like cocaine or meth, you might have a non-fatal overdose, but you have a chance to go to the hospital and come back. They're so potent now, they're just ended up dead and not going to the hospital anymore.
One thing before we move that slide too, to make sure we're clear on this, these are dosage units seized by the HIDA initiatives. This in no way reflects the total dosage units that we purport to have been seized in Indiana. We will also be silly if we didn't admit that a lot of that is what we would call pass-through dope. It is being interdicted on the street. So it's not all seized at a location, but rather a lot of it may well have been seized on the highways as it passes through Indiana, getting to another location. So some distinctions.
Methamphetamine, so as was talked about with the one pot method, Indiana has always been one of the biggest meth using states in the country. We had the highest, I think it was the highest number of seized or meth labs in the state or in the country at one point.
Yeah, we were number one for several years when I was on the department. We would have routinely over 1,000 meth manufacturing related scenes a year just in Indiana.
So those have gone way down as the Mexican cartels make this drug in their super labs. So it's become a lot more potent. So you've already seen, even before the introduction of fentanyl into meth, you already saw a slight increase of meth deaths as the availability increases because it's cheaper to make. And again, it just floods our streets. So meth, 85% availability was high, 59% increased over the last year. It's important to note too with the rankings, once we break them down by regions, Southern Indiana actually ranked meth as a higher threat than fentanyl. Demand for meth, 87% said high, 59% said higher than or increase from last year. And then kind of the same story, total dosage units way up, which is another indication of availability. We're seizing more and more. If we break that down into average of our seizures, for all these drugs, that average keeps increasing. So it's not just that we're, maybe putting more resources out there and seizing more. Each load that we're seizing, we're finding it's more and more. Again, because it's so cheaper to make, they can, volume wise too with fentanyl, they can pack much more deadly doses into a shipment. Heroin. So again, it was unclear, I think, when they talk about availability of heroin, they say it's high. It's hard to know if they're really talking about heroin or fentanyl. Everyone knows that fentanyl is everywhere. Users may think they're getting heroin, but they have an idea it's probably fentanyl and just maybe not care as long as it does the trick for them. So when officers are talking to people on the street, when they're dealing with their informants, they may say heroin but mean fentanyl. It's hard to tell, but our seizure data, our price data, everything says that actual heroin threat is decreasing. Same with demand. So we know crossing the border, well, first we know production's down in Mexico with heroin from DEA data. Border seizures are way down for heroin coming across the border the last several years, way up for fentanyl the last several years. So we know that what's coming into this country is fentanyl and less heroin. We know the actual heroin deaths are going down. Synthetic opioid deaths are going up. Our Indiana HIDA seizures tell the same story. Heroin seizures way down, fentanyl seizures way up.
Quick drug quiz for you. What is heroin made from? Opioid specifically, the poppy, right? You got to score it. It's a lot of work. Okay, perfect. What is the poorest, most uncouth form of heroin that anyone can use? Yeah, black tar. Gonna boot some black tar. There's nothing worse than black tar heroin, right? It's the most unrefined form of heroin. And in fact, black tar heroin, you can smell it before you find it because it's going to have this real strong acidic smell. It's going to smell like vinegar. Okay. What if we were to tell you that cartels, and this has been on the news, so we're not leaking anything, cartels have been caught trying to move fake black tar heroin. In other words, it's a fentanyl, active ingredient fentanyl, and they're moving it as black tar. Now, you're all smart people in the room, and then Adam and I. So what does that tell you? What does that tell you if a cartels, they got all the money in the world, they've got great chemists, they've got great economists work on their business model. What does that tell you if they're making counterfeit black tar heroin? Now it's harder, less pure. What's that? Other way around. People don't want fentanyl. People want heroin. Yeah, there you go, right? So basically what we're saying is we admit that our heroin data is terrible because, one, the police don't know what they're seizing, or they think they know, but they don't know for sure until it comes back from the lab. That's fair. Two, people don't know what they're taking. So, well, I don't really want to take Fetty, so I'll hit the black tar like Grandpa did back in the day. All right, and who would have think it? So now we're seeing people going to be using black tar heroin, air quote time, but it too is going to be a fentanyl-based product. Does that make sense? So one thing to dispel in the middle of this is, while we will be the first to admit that drug abuse and all the problems that go with it are a health problem, sure, but never lose sight that it's an economic question problem also. And cartels are sharp, and they're working workarounds, right? Soon as Pepsi won the taste test, Coke retooled their formula. Then people didn't like it, so they retooled it back. Dated myself with that reference, but a couple old people nodded their heads. All right, I'm sorry. I go ahead.
Did you want to talk about the seizure?
Sure. Highlight. So if you look, kilogram seizures, there's our top three. So this is amount, not dosage unit. This is like true weight. No fentanyl in 2016. But by weight, we're not seizing much of anything, right? Not seizing much of anything. Look at our meth line. Okay, we got a little bit of a dip right here, spike right here. What was that about? COVID, right? What happened at the border? Boom. What happened at the north border? Boom. Ports. Boom. Still dope got through because they're smart. And they also knew that it was coming. We have good data to say that it was getting stockpiled at the border in anticipation of border closings to be able to hold back. So in essence, it was warehoused. And then we've been going straight up. Next one. All right, dosage units, changing it around. Now you see that per dosage per given kilogram, and you're probably wondering how you come up with them dosage units. We use a formula that we are told is sensitive, so we're not releasing it. But we used a magic formula from Uncle Sugar, and is it right? I don't know, but we used it. I'm honest. My life's an open book. So no fentanyl. Now we've got fentanyl. Meth was down on the weight. Why do you suppose fentanyl still went up? Problem solving time. Marketable and remember, this is in dosage units. I don't have to move as much volume to increase my exponential level of dosage units. So if I have limited shipping capacity, what product, looking at price points, but looking at what product am I going to want to go? I'm going to go with the fentanyl. I can get more of that through, more dosage units of that through. Meth is still there. Sometimes if you read ONDCP stuff, they'll talk about the apex drugs. So here's for what it's worth. Our apex drugs, fentanyl, and by ONDCP classifications, that's fentanyl, meth, cocaine, and heroin. So if you look at dosage units, last year, that's our apex drug breakdown from our IDA initiatives. Converse side of that would be the kilograms, where the weight takes meth up. some bottom lines, I guess, for us, for our standpoint. Depending on where you're at, meth or fentanyl is your number one thing. We believe the data implies, that data being survey data, seizure data, interview data, open source data. We believe the data strongly shows us, implies that people don't really want fentanyl, although it has some market acceptance. Everything else being equal, they would like to believe they're taking heroin or a pharmaceutical product. Okay. One quick word on pharmaceutical products. You all know what a bar mat shot is. Is that an old term? That's when you never heard that. So you ever watch them making drinks on a bar mat at the bar, and then you pour everything off of that into a glass, and that's a bar mat shot. A little this, a little that. All right. If you talk to drug chemists, the gals and guys that make their living analyzing stuff and getting ready for court cases, they're going to tell you that pills in particular, but to a lesser extent, unknown white powders are bar mat shots. They're going to have a little of this, a little of that. And it's going to keep changing what that little of this and little of that is. We don't have a slide for it, but one of the final things in our annual threat assessment is we make predictions. So write these down, put them in a glove box, buy your deer tags. I think they're going to be important. No deer hunters in here. Turkey tags then. This is Indiana. We're going to stick our neck out and say opioid deaths in Indiana are going to drop again next year. But we believe that there's a pretty medium, I think we said medium confidence, overall deaths are going to go up. And we're going to blame that tentatively on xylazine, because everything seems to be indicating that xylazine has a footprint in Indiana. Our clandestine sources are telling us it's there. Initiative managers are telling us that they're seeing it. So we know it's here. Needle washes have proven it's here. Other death data has proven it's here. And we're going to have better data now that all 92 county coroners are going to be tested for it. So we're going to be able to come back next year and tell you all that we were wrong or that we were right. But that's that. I think that's the next one. Anything else? Did I miss anything, Adam?
The only thing we didn't talk about much was cocaine.
Oh, yeah.
It didn't rank very high. And the law enforcement respondents, some of them said really high. I don't remember the numbers, but what we've seen in the data is that seizures are way up, like over 300% increase from last year. We know that some of the Mexican cartels have sent emissaries over to Colombia to help with their cocoa production. And it's increased over the last few years based on some of these methods, just basic agricultural methods. So with less and less land, they're increasing more and more cocoa or cocoa.
And the U.S. government is not spraying paraquat anymore. So there is no active steps being taken at the production level to slow cocaine production. So better cultivars on less acreage with higher production. And if you look at, you wouldn't, I see the seizure data across the country. I mean, but we're getting coca leaves are being a thing unto themselves, being used by weight. Still the number one drug, believe it or not, is cot. If you look at pure poundage of stuff coming in, cot, and that's more in certain communities, but cot is around. Probably none of you all have dealt with a cot addict, but you may well have dealt with folks that have used cot. But yeah, I'm not going to be in our threat assessment. This is a personal opinion. I see cocaine as the growth industry. I think cocaine is going to be making a bigger and bigger impact. We'll see what how the price works out the next couple of years. We do anticipate actually including price data in our threat assessment this year, so you can take a look at what we think is happening price-wise. But yeah, I think cocaine is going to be it.
Price has been, cocaine's traditionally very expensive. Price is usually pretty high, but it has slowly gone down from what we've seen. So yeah, I think that's what we're going with at the HIDA is that availability is a lot higher than we think it is right now. And it's gonna continue to get much higher. The question is whether they'll keep putting fentanyl in it, since a lot of those users are dying and they don't necessarily know that there's fentanyl in it. I don't think that's a demand thing. I don't think they want fentanyl in it. So we'll see where that goes.
And who knows what the outlook of fentanyl is going to be? I mean, theoretically, there's around 1,000 or so fentanyl analogs that theoretically could be made. Not all of them have been synthesized yet. Some are going to be weaker, some are going to be stronger. Weaker acrofentanyl, stronger carfentanyl would be the ones that we would know of. But that's certainly going to change, and we know they're going to change their mixtures. It's just the way it goes. And it's going to be a matter too of what precursors are coming across. But China is no longer the primary maker of fentanyl as it was back in 17, 18. That's now south of the border here. So, but they are the primary point of precursors from what we can tell.
Do we have any questions?
Be nice, I'm sensitive.
I have a
My mother
couple
is a-
easy questions. So you pointed out that you only do certain counties.
Yes.
I'm wondering how you picked those certain counties.
Perfect. Could you flip back to that county map? It's like right at the top, and I'll explain to you. So those are federally designated HIDA counties. So county law enforcement, prosecutors, federal, state, local, tribal, come together and they produce a threat assessment dealing with drug issues in a given county. Then it is reviewed by the HIDA executive board in Indiana. And if they approve it, it goes to ONDCP, who has the final say. So when Indiana HIDA started out, it was just Lake County, Indiana. Then Porter applied, LaPorte applied, and then the order gets fuzzy, but our last one was Terre Haute, Vigo County. So that's why.
Will the report you guys are releasing break down by county, or is it just by state?
It's a little of this and a little of that. Where we thought it was where we thought there was something remarkable to say, we split it out by a given area. If it was more or less the same statewide, then we try to make it as terse as possible. So depending on the issue, yeah.
And last one, the last 2 days I completed a Colorado HIDA training. Is the Indiana HIDA planning on doing any trainings based on Indiana?
On what specifically?
They went over youth substance abuse, and they.
Or practitioners in
It was based in Colorado, but they did it online, and they talked about engaging youth, but they also had some local law enforcement and talk about.
okay, talk to me offline because I know the trading guy.
Okay.
In fact, sometimes I sleep with his wife. And a follow-up, you're going to be able to have some visualization when you push out your Tableau part, right, Shrikant? All right, so you may have, yeah.
Hi, thank you so much for this very energetic, awesome presentation. With the emergence of xylazine, so last month with the Marion County Syringe Services Program, over 70% of our syringes had xylazine in them. Since xylazine is not a controlled substance currently, do you anticipate any regulatory changes, or is it even necessary since it's mixed in with the fentanyl?
So I will tread my line very, very clearly. We are a program, not an agency. We handle assets and money and have no influence on policy. How's that?
That was a very political answer. Thank you.
I can be now and again. Yeah, I don't know what they're going to, I mean, just like you and me having a cold beverage, and I'd say, I don't know. I probably, because you look around, you would think so. So probably.
I think with fentanyl or some other synthetic, they did like an emergency control. I forget what it was called, but I don't remember who did it, but it was like an emergency control so they could start doing, I imagine if the deaths get out of control, they can do that and it'd probably be regular.
like we did with the spice a few years back. Yeah,
Yeah,
it's
maybe
going to be
the
something
spice.
like that.
Yeah, that makes sense. Thank you.
Hi, Mary Claire from Allen County.
Hi, this is Adam.
Hi. So we have a hideout up there and we work with Captain Hunter on a regular basis. And one of the things that we have a question about is, we had the release from ONDCP about xylazine being a high contaminant within the supply up in our area and everywhere else, of course. We are seeing very bizarre behavior with people that are thinking that they are taking M30s or whatever, but we know that they have fentanyl in them when they do their testing. And we are believing that there is a lot of xylazine in there, but the behaviors that they have, the psychosis and the auditory and visual hallucinations are out of control. Is this what we think is a xylazine contaminant factor? And does anybody know? I don't know if you guys are the ones, but anybody else hearing that?
Well, I would say you're going to wait till you get your tox back and know for sure, but why not? And then going back to the other thing we talked about, those pills are a bar mat shot. So who knows what's in it until you get a full breakdown. I mean, they could be doing some throwback spice chemical on top of it too, where all of those things were symptoms of the spice. And if you think about it, there's a lot of the open source stuff that I've read on xylazine. I know there's been some calling outs and some auditory hallucinations and stuff. So that part fits. Some of the rest aren't ringing bells. I know you've read a lot on xylazine too.
Yeah, I don't know much about the behaviors or the effects of it.
So basically we're just a couple dummies. We don't know.
The xylazine then is more of an additive that is being used as opposed to a primary substance that we're going to be looking for to be abused.
Yeah, because last open source stuff that I saw, you're looking at xylazine anywhere from $20 to $60 a kilo. So it's dirt cheap. So as long as you can get it in, so if you can have the amount of fentanyl that you're using and use fentanyl in essence to backward step on your xylazine for a little longer, yeah, I don't see why not. Again, it's an economic problem, right? If I'm running my numbers, and if I'm down the drug dealer, I don't want to kill my population off. If I kill one or two, that's the cost of doing business. But I don't want to kill too many, but I want to deliver a decent product and hope it doesn't get stepped on before it hits the street. So yeah, they're going to keep changing.
And does the xylazine not have the addictive properties that the fentanyl does? And is that why it's not the primary substance in your opinion?
No, it'll be because it may become the primary substance.
Okay.
And just with a little added. Because if you talk to old time, I know some of you guys have been in the addiction world a long time. If you talk to, and tell me if you've heard something different, but you talk to the old school users, they'll say that the new stuff doesn't give you near the ride a good heroin from the 70s did. So it's going to be trying to balance that ride.
Speaking of changes since the 70s, any word on what if xylazine or any of these other substances are being added to marijuana, which has obviously different impacts now than it did with its potency?
Okay,
Because
that one I can talk about.
I know that with fentanyl, there's a burn rate and it becomes less effective if they burn it instead of wax or whatever. So what about the other drugs that are interacting and that's being put in the marijuana supply?
Yeah, so putting crystallized fentanyl in marijuana, from what I've read, looks like that's just wasting perfectly good fentanyl. You're not going to get anything out of that. It's gonna burn off before you can inhale it. Xylazine looks like preliminarily that you may be able to smoke that.
I thought.
Now, how are they going to smoke it? I don't know. If they're going to mix it with plant material or if they're going to go old school with some steel wool and a pipe, I don't know. But think about how cocaine morphed. You had your powder, your blow, and then you had your freebase, and then you had your crack, and then we're kind of coming around. We're not going to see freebase again because there's crack. But so I don't know. But yeah, probably like that, probably.
And is marijuana not one of your top substances because it is not as pushed by the cartels because it's legalized in so many places now?
No, it's not the apex drug according to ONDCP, and our law enforcement responders did not indicate it as in the top 3. By weight, it exceeds. Yes.
Okay.
Yes.
It was not, did I miss it? It was not up on the
It
board.
was not on the screen.
Okay,
You did
that was
not
my
miss
question.
it.
It was like 4 or 5 though, it ranked
Because
pretty
that
high.
cat business, I've never heard of it until you just said it. And
Oh.
my colleague sent me the information on it because I had no idea. So I was surprised that that was on there, but not marijuana.
Well, I just mentioned cod. It's not on there.
Oh,
I'm
okay,
just-
okay. I
Yeah,
was
no,
confused.
but marijuana's on there. It's just down on the list. Well, here's a free fact. We did the price analysis for what it's worth and looking at the prices, our UCs are paying for marijuana versus dispensary price. You have a 30% discount on the black market. So put that in the back of your mind when you're talking to clients and whatnot. That black market dope is going to be roughly per ounce price, 30% cheaper.
I'm probably not going to tell them that because I would like them to get it from a dispensary if they're getting it at all.
That's fair.
But just saying,
That's fair. That's fair.
I'll tell the providers though, not the clients.
Share with whom you see fit. How's that?
Thank you. I appreciate you.
Yeah. Anybody else want to?
We are seeing similar symptoms as what she has described in the Vigo County, Sullivan County, Greene County area. And
I love Southern Indiana though. I love it. It's beautiful.
yeah, it's gorgeous. You said they're testing in all 92 counties. I have not seen that. Our drug-free communities is actually in one of the local police departments. And I see fentanyl come up on the reports often that are released, but I've not seen xylazine, but it makes me think that it is.
So this is what I can tell you based on direct communication from the Lake County, Indiana coroner. He said at a meeting I attended, all 92 counties are testing for. So you may not see it until you have death data, but they should be pulling, I don't know if it's eye fluid or blood, whichever they're testing for it, but there should be moving forward xylazine in death reports. Now, what's coming across the lab for analysis on a seized substance, that I don't know.
Okay.
That I don't know. And the other problem is police aren't set up to field test it. So it becomes an unknown white powder and they're not going to get it tested if they have weight on something else because that takes up resources. So that's always going to be a data lag.
That helps a lot. Thank you.
I know. I got.
Oh, I know you're fixing to come up here, Dane.
I know. I'm not. I had to ask a question. So for like,
We'll get even with you in a minute.
for the community level people, so can you speak to who the primary like street level distributors are? Is it criminal street gangs? Is it motorcycle gangs? Does it vary by
That's
type of drug? If communities are looking to make a dent and sort of do some prevention, who is it that they're looking at in terms of distributing?
Adam is the DTO man right there.
So on the street, we're finding a lot of the gangs are fracturing. Motorcycle gangs are a little more organized. But that's one of the questions we asked in the survey. Who's actually distributing at the street level? It was like 20% said it was cartels are actually on the street. And overwhelmingly, it was just independent DTOs. So just neighborhood friends getting together, selling the stuff. Yeah, it doesn't seem very organized anymore. You know, like it used to be with the street gangs. It's just.
You got a plug, you can deal,
Does that
basically.
answer your question?
Yeah. Yeah. So, I mean, that's because like not being from Indiana, I thought there would be like a really strong centralized gang presence here, which I haven't necessarily as far as the drugs go. Maybe I could be wrong on that.
Probably for the last 10 years, the theory, I guess, from law enforcement is that when you had the Gangster Disciples and all those big ones out of Chicago, they had leaders, they were very organized and structured. Law enforcement took out the leadership and then they fractured from there. Now what you have is, you know, we call them neighborhood-based gangs or cliques. They might have an older brother who was a gangster disciple or was, you know, whatever traditional gang, and they might claim it, but they also claim their neighborhood. And they're not very loyal to the gang and they're not very organized.
And then the last question is have y'all done anything looking towards correlations between some of the HIDA areas or like in these neighborhood-based gangs and things like that, and homicide rates or gun violence? Because I know that I've seen other studies where there's been connections between the two. Knowing what we know about what's happening in Indianapolis with the homicide rates and things like that, it seems like that could be something that could be beneficial for future iterations if that's not something that's already been done.
You mean with the fracturing of gangs? So more gangs now means more violence?
Yeah, more gangs, more violence, more turf wars, things like
Yeah,
that.
I talk about it a little bit in the threat assessment because there was an article about the DTOs in Mexico. Pretty much in the same manner, the last decade, the number of DTOs has doubled. So they're talking about more competition in Mexico, which means a lot more violence. They're all fighting each other. A lot more competition with the drugs. So a lot more drugs coming through, a lot more traffickers. So that's kind of what I've seen here at the retail level. And yeah, some of those crime statistics show that it could be a correlation there, but I don't know that there's really good data on the neighborhood-based gangs and the fracturing. It's just, law enforcement interviews. Okay.
So, realizing that I'm kind of a huge nerd about drugs, which may or may not be the best thing for this field. So, do you think one of the reasons why xylazine has exploded in popularity is because of the side effects of desomorphine? And do you think if there were any as horrific side effects, then we would see a decrease in it?
So you jump in if you think I'm all wet. Desomorphine, from what I understand about, or crocodile, the desomorphine, using it is not going to cause the necrosis. The problem was that it was such dirty dope that they were shooting in the Eastern Bloc. That was causing the necrosis, or at least causing most of the necrosis. Here, I don't think you can say with any real definitive answer is the xylazine causing the necrosis, or is it exacerbating, let's be honest, I mean, most intravenous drug eaters are not necessarily the most hygienically conscious people to begin with. Are they just, is it causing something to exacerbate an already iffy situation? I can tell you this, back in the day with my agricultural roots, used xylazine in horses and cattle, and I never had a bad shot, and I never had open sores. So I don't know. That's kind of a soft answer, but time's going to tell. But I don't think it's a fair, based on what we know now about crocodile, I don't know that it's necessarily a fair comparison. But I thought the same thing when I started reading about all the weirdness associated with tranq.
Yeah, I was gonna say when synthetic marijuana started, and then all these other drugs, bath salts, those were supposed to take off. But I think with those side effects, the zombie or whatever the different side effects were, those kind of went away. They're not really that much of a threat anymore. Yeah. So
Keep a roommate.
the other thing too is when fentanyl started becoming popular, carfentanil started becoming a thing. And that was supposed to replace fentanyl because it was that much more potent. I don't know enough about carfentanil, if it was just too expensive to manufacture, wasn't worth it, but that threat didn't materialize like we thought it would. So xylazine may, kill people too quickly, and it goes away. The drug cartels are billion-dollar industries. So with the rainbow fentanyl as well, they just kind of throw things out there, see what sticks. If people don't like it, then they can change it up.
Where we were wrong.
Is this being recorded? All right, thank you.
Well, thank you very much, Dr. McKay and Mr. Adam Fabridge for that wonderful presentation. Up next, we will be having Dr. Dane Minnick. Dr. Dane Minnick is an assistant professor in the Department of Social Work at Ball State University. and the Executive Director of the Addictions Coalition of Delaware County, the Director of the Ball State Center for Substance Use Research and Community Initiatives, and a former fellow with the Substance Abuse and Mental Health Services Administration Center for Substance Abuse Prevention. Dr. Minnick's research and practice experience has been centered on the development and implementation of community environmental strategies to address substance misuse. And he is a licensed social worker and a board certified in substance misuse prevention and problem gambling. So Mr. Dane Minnick, please take the stage.
Well, no, and there's not enough of us that are in the addictions field. I can tell you, it's such a broad field, and I'm always preaching that gotta merge the two at some point. But that's a different presentation. But yes, thank you all for all the social workers in here. Like kudos for being here, as well as our other prevention specialists. People gotta have a lot of appreciation for that as well. Where are we going? I hope am I going backwards or forwards? All right. Okay, so I was going to talk about two different things, and I realized in 30 minutes I was not going to have enough time to cover both. So I picked the one that was a little bit more fleshed out. So this one in and of itself is an exploratory study that we've been doing to look at syringe service programs in Indiana. So do we have anybody in here who's from a county that has a syringe service program? A couple of people, yeah. All right, so yeah, there's a couple hands up there. I was going to be surprised if we had an overwhelming amount because there's not a ton in Indiana right now, which is a little bit surprising once we get into some of the statistics here. But as somebody who at one point in time tried to bring a syringe service program to Delaware County, we got in there, we had a meeting with our county commissioners, went through the whole process, and they had some questions that we found out that we weren't necessarily able to answer at that point. Specifically, what kind of outcomes were we getting in our state? And then looking at the data, as some of the questions arose is, are we going to see this massive skyrocket in crime? Is there going to be a massive amount of overdoses that happen? Anybody that's fielded questions about syringe service programs before is probably some of the questions that you're familiar with. So we put them all into a survey and sent them out to the syringe service programs we're operating in Indiana. So I want to give a big thank you to Erica Chapman, who actually kind of helped make a lot of this happen. Without her, I don't think we would have been able to get the access that we did or be able to answer the questions after. Hopefully engendered the trust in terms of providing some of the information going forward. So for those of you who are not aware of what a syringe service program is, so it is I don't know which way to look on here. Got it over there. Maybe I should step out. Well, then you're not gonna be able to hear me. All right. So it is what I consider a public health as well as a medical intervention. Obviously, the main primary point is to exchange points or give safe syringes to people so that we can prevent disease, specifically hepatitis C and HIV. But more importantly, and for the social work in me, is this is providing an access point to what is probably the most vulnerable population that you're going to be dealing with in the state, in the country. These are people that oftentimes have issues with housing, have food insecurity, have medical issues, mental health issues, just kind of running across the gamut of everything that we're looking at, and often a group of people who we don't necessarily have a ton of contact with outside of potentially law enforcement. So this provides basically a way to gain trust with this highly stigmatized and marginalized population, and to be able to provide some essential services such as food and clothing and housing resources, insurance navigation, all of these different types of healthcare, and then treatment and recovery resources. And then at this bottom point too, when we're talking about treatment and recovery resources, we're talking about being able to provide this in a way that reduces recovery barriers. Does anybody know what I'm talking about when we're talking about recovery barriers? For those of us that are in the recovery field, if you have a client that comes in that's facing $100,000 worth of fines, looking at 6 years in prison, it's going to have a really long rap sheet. just charges over and over and over and over and over and over and over again, what does that do for your long-term prospects in terms of getting a job, in terms of becoming a functional member of society, in terms of being able to give back, in terms of being able to escape stigma? But it's a bad proposition. It's really counter to the entire recovery process if we're going to put 10 years worth of barriers in place just to be able to get to a point where everybody else is at. So this is providing a way to get an access point to these populations without essentially putting stigmatizing and additional barriers in place for them to get to the point that we're all driving to get people who are entering the field of recovery to get to. All right, so I got a couple of maps here. I'm not going to spend a ton of time on them, but we're going to, and y'all been seeing this data kind of throughout the day, so that helps too. But these were our non-fatal emergency emergency department visits for heroin in 2019. And you just got to pick out where your county is at right here, and you're going to be able to see a little bit of a pattern of where these things are. So we talk about syringe service programs. Heroin's always going to be part of it. My favorite is here looking at this East Central Indiana one. We have Delaware County and this circle. I was looking at the county that I'm at specifically just to see if there's a need there when we're looking at when we're talking to elected officials, key stakeholders, things like that. We got our opioid overdose deaths. Here you're going to see a lot of yellow. If there's counts less than 5, in some instances it's 5, in some instances it's 20. They won't be on the map right there just because of data use agreements. Newly diagnosed HIV and AIDS 2021. We'll show some statewide figures here or some nationwide figures in a second, so y'all can kind of get a sense of where Indiana's at as far as the country goes. And then we see our HIV and AIDS prevalence. So these aren't the new cases. These are just what exists in the state right now. And again, as you would kind of expect, Indianapolis, Marion County is going to be a central point for this just because of the way the population is relegated in the state. And then here's our big one is our acute cases of Hep C, our new cases of hepatitis C, which is kind of a primary focus of syringe service programs. And up there, you can see where we're at with our Delaware County area, East Central Indiana, up there in the top left, and then obviously Marion County right there, and our chronic hepatitis C. So again, painting a picture of what's happening in the state. Finally, opioid prescriptions. When we talk about syringe service programs, I'll just get into some more of the details about this. One of the key things that you'll hear in a talking point about syringe service programs is whether or not it can increase overdose deaths. So that's why you've seen some sort of opioid statistics here, and they're going to tie in as we go forward. But again, I like to just kind of point out where the central location is. If you're looking at East Central Indiana, hopefully you've been paying attention here. You can see some of the problem areas that we have here in the state that can be a focus going forward. All right, so for our syringe service people here, or anybody who's ever tried to start one of the things that you may hear is crime. And people will say that when you're having syringe service programs, that there can be potential increases in crime because obviously you're kind of decriminalizing in that instance the possession of syringes. So what we've done as part of this analysis is look directly at crime statistics. So if you're going to have discussions with your community, you can say these are the crime rates that have happened in Indiana and in our state, and you can say directly whether or not what we know in our state, if syringe service programs increases, decreases, or has crime remain the same. So try to keep this really, really base level because obviously being exploratory, not running significance tests and things like that. I didn't want to get too cutesy with the statistics here because I know, especially if at the end of the day, nobody wants to hear about p-values and things like that. So there you can see crime reduced, and we talk specifically about drugs. Down there, you've got 2012 all the way up to 2022. These are arrests and dispositions for the state of Indiana. I'll have a little bit of a spoiler alert here. I think the first SSP in Indiana started in 2016. And so if you're looking at crime rates both here and in 2016, you can say unequivocally that our arrests and our dispositions decreased across the state over that time period. And we're going to talk about whether or not that happened individually in the areas where the SSPs were operating. So where does Indiana look like nationwide? So raise your hand if you're familiar with our hepatitis C statistics before today. A couple of people, but they're not good. But though they have gotten a little bit better. So you can see up there, 3.6 people per 100,000. In 2018, we were the #1 state in the country for hepatitis C rates. #1. Fortunately, we've got down to #6 now. And we've got it noted there. One of the reasons why that's important, throwing economic figures out there, can be about $84,000 per person for treatment for hepatitis C. So pretty good idea to, just from an economic standpoint, to use prevention as a measure for this disease. Next, you can see we were 25th in new cases for HIV. Midwest, thankfully, is not a hot spot for this, kind of there in the middle. It's more the southern part of the United States that's been having the HIV issues. So while you'd like to be at the lower end of that, that's thankfully not top 10 where we've been in some of the other statistics. You can see there 10th in overdose mortality rates, and that our overdose fatalities increased 38% from 2019 to 2020. It's kind of mirrored overall national trends. And then down there, I'm not going to go too far into it because it's like relatively new. And I know that Wallet Hub doesn't sound like a super reliable source, but they just did this really in-depth analysis, ranked us 12th out of all the states for worst substance use outcomes. You can go through it. If I had my notes in front of me that I was actually looking at, I could list some details and stuff from that, but it ranges everything from drug arrests. I'm not even going to try to list all of it, but it's got some really good information in there for any of you data nerds that are out there that want to get more in depth into it. All right, so overall, this is just a picture of what it looks like across the country when we're talking about hepatitis C. You can see Indiana up there in the middle. It's actually Florida is right now kind of leading the way, I think, in the country for this. And then for hepatitis C cases, the actual counts, not the per 100,000, but you can see there, 2018, 2019, we skyrocketed. And then go down. And I'm going to say 2019 because that is somewhat of an important statistic. Again, let me get into it. Just everybody keep kind of that 2019 in the back of your head as we go forward. So here we have our new cases of HIV. I already mentioned southern part of the US, not the place to be right now for that. And then we've kind of been pretty stagnant in terms of our counts for HIV across Indiana. One other caveat about that, though, does anybody have contact with their street outreach teams? So what are your street outreach teams telling you right now about the potential accuracy of hepatitis C rates and HIV rates that they're coming across in their individual counties? They're giving us thumbs up on it. They're saying it's, I can tell you that I work directly with our street outreach team a lot right now, and they have expressed some very serious concerns about a high level of undercounting of hepatitis C rates in our area, which is that Delaware County area. I don't know if it's the same across the board, and I just wanted to make sure and put that out there as we go forward, is just discussions with people about this, and we've already talked about data and what we do know and what we don't know. When I reviewed this with the street outreach team and had talks about it, and specifically looking at our county, they felt that it was probably pretty dramatically undercounted in our area. So it may be the same in other areas, it may not be, but it's something to keep in the back of your mind going forward. But for what we do know, this is basically what we're presenting on today. So let's talk about our syringe service programs. This is a map of where we are at right now. So if you think back, one of the reasons we flashed across where the dark points were on the map, we're hoping that would correspond some with where our syringe service programs are. And the blue is our non-syringe harm reduction programs. So those ones where you can do wound care and you can provide a couple of different resources that are provided by IDOH. The red is where we actually have included the syringe service programs. And we captured, I think, 8 out of 9, something like that. You'll see here in a second. So what we did, as I mentioned earlier, is we sent out a survey asking for some specifics about what each program is doing and what the outcomes that they are producing are. So we want to know, one, program logistics. When we saw earlier, it's talking about not just the exchange of needles, but what are the tangible resources that you're providing to this population? Is it clothing? Is it laundry services? Is it a place to eat, a place to shower? Pro-social connections, things like that. So we had a list of questions, and then we also provided a chance for programs to add in additional resources they would provide to clients that they serve. We also asked to provide the number of individuals that each program served individually, as well as like the total number of people. So if there were repeat services being provided, and then the number of treatment referrals provided, as well as number of successful referrals. So do people actually enter treatment? Now, keep in mind, when we did this, we did not necessarily have a great idea about if this was even going to be how much variation there was going to be across programs. So if two of the 8 programs were going to be providing treatment referrals, is that something that's featured as part of it? Is the other one, is the need so high that you're not providing treatment referrals? Also, are you operating across the state? So if we're located in like, for instance, the county, if you're making referrals to people that may just be coming across like 2 state lines, you may not have necessarily the connections to be able to do that. So this is all just first time around, hopefully going to be able to build off of this. All right, so after we collected the data, we then went and looked at our public health outcomes, Hep C, HIV, and then looking at overall treatment emissions that were recorded, overdose fatalities to see if programs were correlated at all with an increase in overdose fatalities, if there was an increase in emergency department visits, and then again, that key one, if you have an SSP program, is your county overridden with crime afterwards. So we're going to start off, the one county that had data that was usable sort of across the board was Marion County, which is to be expected when we have a certain number of counts that you have to use to be able to provide accurate, sort of a semi-accurate picture. So it was started in 2019. So we got 3.5 years worth of operations, 3 employees, didn't have any volunteers that were identified in the survey, requires a membership for participation, open Monday to Friday with varied hours, mobile and central locations, and then services both Marion County and surrounding counties. Some of the services they provided: wound care, recovery coaches, vaccinations, HIV, Hep C, and STI testing. Indicated that there was good community support and good support by local elected officials. So this is what we've seen since they started. So they started off, you can see duplicate services. So that can be somebody or just the total number of service provided, not necessarily unique individuals, was 1612 up in 2022. And you can see it's grown every single year since they first started. For unique individuals, 1,030 in 2022. And then the number of treatment referrals stayed pretty static there at the bottom. For Marion County, for Hep C cases that were reported, and again, this can go back to how well things are being reported at the time, but as far as data that we have, or what we know, this is what we can show for right now. So our cases dropped by 60% from 2019 till now, when the program was first implemented. Obviously, we have a pandemic that happened during that time. And again, we didn't do any significance testing. But in terms of just overall descriptive statistics, if you tell somebody that a program started at one point in time and that Hep C cases dropped 60% from the time that it started, and you're talking about this in the context of being a state that was #1 in the country for hepatitis C 4 years ago, that is an extremely important statistic. And I cannot overstate that enough. We are #6 right now. And we have a program that just showed they could or that they didn't show, but it has a descriptive statistic saying that hepatitis C dropped by 60% since it started. You don't get public health outcomes like that with very many programs. Next, we can see HIV cases. Again, not a huge decrease here from 229 to 219, but you can see the dip there. Endocarditis, which is a condition that's strongly associated with intravenous drug use. Again, we have a large dip here from 2016 down to 2018, but again, remained very low and remained stable. And then we talk about crime. Well, here we can see our overall crime statistics. Starting at 2019, dropped down to 2020 across the board. stay lower than when we started. Same with drug crimes specifically. So I would never, ever in a million years say that there was a reduction in crime because of a syringe service program, but I can pretty solidly state that what we're seeing there is that it didn't cause an increase. That is 100% for sure. All right, so next up, we have our Connection Cafe. These will go through a little bit faster now, just because there's not as much data associated with the rest of them. We kind of led with the one that we have the most information about. Started in 2016, 6.5 years, 8 regular volunteers, doesn't require membership, 600 individuals served in 2021 and made 100 treatment referrals in 2021. They're open Tuesday to Saturday, varied hours, mobile and central locations, are connected to their street outreach team, which we found could be very useful, especially in some of the more rural areas where access, especially if you're trying to serve multiple counties and transportation can be a barrier. Street outreach teams, they have unique access, at least in the experiences I've had with the street outreach team that we've had in Delaware County. Positive community support, positive legislative support. Offer housing, wound care, meals, food pantry, access to treatment, recovery coaches, vaccination, showers, laundry, career services, HIV and Hep C testing, and that pro-social activities. So if we're talking about a sort of pro-social intervention for a marginalized population that's coupled with incentives to draw them in, i.e. the being able to get clean points so that you don't get diseases. This is probably a model program on how to do that. It's, again, we don't even list the points necessarily on here, points being the needles, just because of the importance of the outside parts that are being brought in. Again, no increase in crime, no increase in crime. You are going to see we're going to go through real fast on that because it ends up actually just as another spoiler, not a thing that ends up being part of the presentation. So, but we have to put that in because I've had some people already request to be able to use this going forward, and you have to be able to show this. So Madison County, 4.5 years, 5 part-time employees, no membership. Open Monday, Wednesday, Friday, mobile and central locations, services other counties, low community support, however, and neutral legislative support. I think one of the people I talked to about this said that the local elected officials said it was a necessary evil. I think was the way that it was described. Just interesting when you're telling the people that work at the program that you're a necessary evil. I thought that was funny. Wound care, recovery coaches, Hep C and HIV testing. You can see here with their service outcomes, they served 2022, 985 people and made 369 unique, or had 369 unique people served. No crime, no crime. Next way, Gateway to Hope, 207, operating since 2017, 850 individuals served in 2022, 500 treatment referrals made in 2022, 3 employees, 24 volunteers, no membership. They also have mobile and central locations connected to their street outreach team, services other counties, strong community support and legislative support. Housing, wound care, treatment access and recovery coaches, vaccinations, MAT services. I think this is the only one I saw that had MAT services. Showers, laundry, career development, HIV, Hep C, STI testing, clothing and transportation services. So another one-stop shop. And here you can actually see there was a modest increase. So it's our single one. If I had the percentages right here, I'd be able to say it, but I don't. And here you can see our drug crime has gone up in this one. So the 1 out of 7 counties that we had the information for was the only one where this showed up. Next up, Clark County, 2017, has membership, central location, connected to their street outreach team, services other counties, neutral community support, and neutral legislative support. They have wound care, vaccinations, and testing. And here we can see their outcomes. So you can see it's like 600 some odd services provided. They provided almost the exact same number of treatment referrals as they did for a number of clients. And you can see there in some instances for their success of reported actually getting people into treatment is extremely high. So I think we ended up with 2 programs that showed really strong promise in terms of the increasing access to treatment and actually bringing people in. One of the primary things, I think it's people who enter into syringe service programs are 3 times more likely to enter treatment than people that don't. And so the outcomes that we've seen with some of the programs that were tracking that, and at least from what we saw in terms of the data, showed very strong promise in not only meeting that sort of goal, but actually exceeding it in certain instances. And here, back to the standard of no crime and no crime. Next up, we've got Allen County, 2016, 5 employees, no membership, central location, services other counties, and it's got positive community support and legislative support. You can see they give wound care, access to treatment, vaccinations, HIV, Hep C, and STI testing, and that insurance navigation component. And here, oh, I didn't have this one saved. So the total number of individuals served is the gray line at the top. So 1364. The number of treatment referrals made is in orange, and that is 455. And then the unique individuals served is 190. And crime basically staying the same, though. If you look at 2016, I believe when this one started, there's a dip there. Same there. Next up, Wayne County, 2016, 3 employees, 5 regular volunteers, no membership, open Tuesday and Thursday with vary hours, and central location. Also serves other counties, low community support, neutral legislative support. They provide housing assistance, wound care, meals, access to treatment, recovery coaches, vaccinations, HIV, Hep C, STI testing, and treatment on site. And then Wayne, and then you can see here with their outcomes, the total number of services provided was 1578. Treatment referrals were 1446 just for 2022 alone. And then you can see unique individuals served was 553. And our treatment success rate down there at the bottom, I can't read it. Y'all can read it though. So had some good outcomes in relation to what they were doing here. And again, crime mostly remaining stable, though dropping from when the program was first implemented. And again, dropping from when the program was first implemented. There. So when we tried to look at hepatitis C rates for individual counties, the data was unstable. So we weren't able to, other than Marion counties, we weren't able to look across the board and be able to make that connection there. We were only able to look at the statewide statistics, which when I showed you, we had the 60% drop just in the one county alone. I think it was around 40% overall for the state between 2019 and 2022. So if we're talking about servicing multiple counties and multiple individuals, y'all just saw the number of people that were served by that. We were mostly looking at 2022, but that's thousands and thousands of services that have been provided by the SSPs in Indiana since 2016, 2017. You can make a case, so we're not going to be able to prove it because we don't have the data to be able to make the appropriate statistical comparisons. But purely from a descriptive standpoint, it looks like it's working. But I can't make any strong, or I couldn't speak 100% accuracy on that, which is why we have it listed here. Same thing for HIV, just unstable data on there. We can only look at what our statewide rates are and see if there's any sort of correlation between when the program started and after, and obviously trying to account for changes that occurred as part of the pandemic. So on to our opioid overdose deaths, which I think somebody was talking about. I had a conversation with somebody just a day or two ago about how their county commissioners were wanting to get rid of their program because they said it was leading to increases in opioid overdose deaths. So this is going to be tricky, probably even more so than some of the other ones, because here you can see we have data up to 2019. And if you're looking at overall rates for overdose deaths, just across the country, Indiana in general, there's a giant spike that occurs in that 2019 to 2020 range. We'll show you the data here in a second, but you can see for our counties here that participated in or that have an SSP program, we don't have a ton of any real strong statistics that necessarily jump out in terms of increases in overdose deaths. So if you're looking at this, you would expect as the programs progress and if it was encouraging it, that you would probably see an increase as the years went by. And here you can see that there's from a data standpoint, it's kind of all over the place. And you can see here in the middle, there's a big jump, but we don't see a trend that we would expect to see if SSPs were leading to overdose deaths. For our for our opioid overdose, our non-fatal overdose. Yeah, that was the emergency department division, sorry. For our opioid deaths, you can see here that we do have our trend that's kind of somewhat spiked in certain areas. Over here in Wayne, you can see it jumps up way high, jumps back down. So you would say that we kind of have a little bit of a pattern here that may be a little bit worrisome on that. So you look at our slides here. This is our statewide rates. So we just looked at the 8 some odd syringe service programs here. There's a massive jump from 2019 to 2020 across the state, showing that this is a problem. And we could go county by county and look at the outcomes here. There's a massive jump in opioid overdose deaths across the state and across counties, regardless of whether or not an SSP program is operating there. So in looking at that, again, we're going to have to do some more statistical analyses on it, but from a descriptive standpoint, it didn't appear at first glance like there's any sort of connection between the two, particularly when you look at what happens across the nation. You can see there, 2020, 2021, massive jump, a massive jump across all states in the United States. So it would, again, just purely looking at this from this first general exploratory standpoint, it's going to be really hard to make any sort of connection there between overdose deaths and operations of SSP programs in Indiana. Here we can see our treatment admissions kind of jumping across the board. I'm not really actually sure what we were hoping to see out of this. You hope that treatment admissions go up as you go forward because you're getting more people into treatment? Are you hoping that perhaps referring to people treatment earlier, that it would be going down there at the end? So I'm still trying to work that out in terms of what, when we decide to publish on this, what our expectation or what the overall outcome is going to be on that. Because I feel like it's just kind of dealer's choice at that point. Like, are you looking for, are you hoping that treatment admissions go up, or are you hoping that they go down? And is your logic behind that? What is it? Next up, overall opioid treatments, same thing with heroin. You can see, again, with Marion County being how we would expect leading the way on there. But again, kind of all over the place. And then you can see that the patterns are a little bit different between each county. So what should you take away from this? Other than, well, it's an exploratory study. Well, one, we can say that, again, from the descriptive standpoint, that Hep C rates decreased by 60% in Marion County since the implementation of the Marion County SSP. Again, and so I guess I promise this will be the last time I say that. You cannot say unequivocally that one is connected to the other. But you can say that the program started in 2019, and since then, rates have decreased by 60%. For the second part, hepatitis, oh, see, I did have the statistic here. Hepatitis C rates decreased 49% statewide from 2019 overall. So those are with all of our SSP programs operating. That's pretty staggering figure. It's also pretty staggering that we're still 6th in the country for hepatitis C rates. Number 3, HIV rates have remained stable since 2016. Number 4, there's been a 31% decrease in annual drug arrests since 2019. So take that for what you will if we're having more programs open. And if that is at all connected to changes in law enforcement's perception of public health versus incarceration. Number 5, crime has decreased in 6 of 8 counties where an SSP has been implemented, with 1 remaining relatively stable. So from that, when we finally get to do the analysis, I think you can say pretty clearly that there is not any evidence of crime increasing as a result of an SSP operating in a certain area. Yeah, you can stand by that one for sure. And then finally, thousands of at-risk Hoosiers, our most vulnerable population, have been served by these programs with some of the most needed resources, or some of the most needed services that are needed by this population, from food, clothing, housing, and then obviously keeping them healthy and reducing barriers to treatment and providing an additional access point to be able to provide services. So I wish we could be more sure in our statistics on this, and we could do more than just the descriptive, and maybe at some point we'll be able to, as the analyses go forward. The hope is to be able to refine this as we go forward and be able to build on it from year to year. So eventually we can show definitively what the outcomes are associated with some of the Hep C and HIV rates, and really have the evidence to support everything that we're doing. But as far as what we do know, this is it at this point. And I think it paints a pretty, at least in terms of from a statistical standpoint, a pretty positive picture of the potential for syringe service programs in Indiana. All right, so questions?
Hello. So within the past couple months, Vigo County's health department released that our county is seeing a spike in HIV cases. So my question is, how are these programs even getting started? Because it's been insinuated that if our agency wanted to take on doing a syringe service program, that we could be arrested for handling needles and syringes and passing them to people.
Yes. So it is a tricky proposition. So the first, Erica Chapman from IDOH is an invaluable resource on this and can walk you through the steps. I can tell you that the actual steps are, there's a couple different, the primary approach is you have to get your county commissioners and your local health department on board, and there has to be a measure that's approved that declares an emergency in the county, and then with the approval of the health department and the county commissioners, then you're able to start one. Without that, we haven't been able to find a way forward for it in my county. But yeah, you can. If your prosecutor decides that they want to arrest people with syringes there, then they can and they will, unfortunately.
Thank you.
It's not a great answer, but
So I guess the second part to her question, because I've been working with this since we found out that our numbers were above the threshold, is I think the commissioners, public officials, I don't want to blame it all on them, don't want this, and they want to maybe not encourage testing, because that will make it go away. How do you work around that? Have you seen that before?
man, it's just I knew there was gonna be some loaded questions here. Right? So my advice on this is coming from like a research sort of standpoint, and somebody that works in community academic or community partnerships and things like that, is evaluation. And that if there's a problem with testing, that you come out and you say there's a problem with testing, and you make that an issue. If it's talking about it with local community members, with whoever it is that you need to talk to, if there's active opposition to it, then I think that's a problem that no matter who you are, you can say that that's ethically an issue. And it shouldn't be happening as far as elected officials are concerned. So you can start there. But the efforts that I've seen happen are that you take data that shows what your outcomes are, and you connect it to the policies that are in place. And then you connect it. I mean, one of the reasons, if you real to this, we kind of made the presentation specifically for community member people, especially when you're like, why did he throw in that it's $83,000 a year for treatment? And you're like, well, if our county has 25 cases and we're not doing anything about it, and then you can connect the dots like fiscally, and then you can talk to certain people and use that as a way to evaluate what's happening and show that, broadcast it that this is a problem. So basically shouting from the rooftops that there is an issue, and then you show what the data is to try to make changes. Again, not a great answer. I'll say epidemiologically, one of the number one problem is that the people that are in charge of approving these things and making these decisions are not public health people. It's a reality. It's people that frankly don't understand all the time. So.
You made a comment about testing and numbers being off. Wanted to come back to that.
Mhm.
Do you mean HIV numbers, Hep C numbers, both? And then if you could also just educate me a little bit about Hep C testing and when that happens. Does someone have to specifically say, I want to be tested for Hep C? Is it if symptoms, or is it part of a panel that might be done as far as STD testing, something like that?
So, all right. So for the first part, what I've been told from at least the people that I've spoken to, that it is HIV and Hep C as far as what could potentially be off. And I'm only speaking specifically from the area that I was in and the surrounding areas. So you can kind of limit that. I'll stand by the East Central Indiana comment about our numbers potentially being off, just because that's where our research center is connected and where my connection. So I can't speak for anything else. And as far as testing goes, the way that at least for the population we're talking about for like syringe service programs, the way that we've tried to do it is just to make it as essentially as available as possible and as many locations as possible. I don't think that we actually do it on our health department right now, and that's one of the things that we've been trying to bring there. We have 4 or 5 community partners that just offer it like whenever they can. So like our street outreach team will connect with different service providers and try to do it through there. So it's really like going out and actively encouraging people to come in and do it. But as far as reaching this population, they don't have like there's not a solid strategy in place right now to be able to do that testing. In fact, that's one of the good things. I had testing and assessment originally on the slide. I took it off because there was too many points on it to read. But the syringe service programs, I mean, it's an excellent place to be able to do that, to be able to reach that population. But yeah, that answer your question. All right. Well, thank you. Hopefully I kept people awake there at the end without too much p-values and things like that.
Thank you very much, Dr. Minnick, for that very informative presentation. Next up, we have Ms. Caitlin Rupp. Ms. Caitlin Rupp leads the evaluation team for the Tobacco Prevention and Cessation Program with the Indiana Department of Health and has been working in commercial tobacco control since 2007. Caitlin has a master's degree in psychology from the New School for Social Research and lives in Indianapolis with her husband, Joe, daughter, Julia, and 2 dogs as well. I welcome to the stage, Ms. Rupp.
Thank you for that introduction, and thank you to those sticking around for the last session of a day on a Friday. So let's see. I'm Caitlin. I'm from the Indiana Department of Health Tobacco Prevention and Cessation Division, and I head up the evaluation team there. So I'm just going to be talking about evaluating the Indiana tobacco control movement. It sounds really broad, but I'm going to be honing in on 3 specific areas in the time that I have. So bear with me. All right. So here's our mission and vision for the Indiana Department of Health. And then this is what I'm going to be covering today. So I'm going to give just a broad overview of our work and our team's work with surveillance and evaluation for commercial tobacco control in the state. I'm going to touch on the adult tobacco survey, which is an adult survey specific to tobacco-related content in Indiana. Evaluation of our community programs around the state. We fund about 45 community-based organizations to have tobacco control coalitions embedded at the county level. And I'm going to touch on youth and young adults programming. Shrikant wanted me to mention that, talk a little bit about that. So happy to talk about that. And then some of our future plans for evaluation. So thank you to Shrikant and thank you to the SCOW for having me. So this is our evaluation team at IDOH for tobacco prevention cessation. And these are the people most involved in the work that I'm going to be sharing today, and really fortunate to have them on my team. So Brandy, Mahi, and Jeff. And then this is what our work encompasses. So just like high level, we run a lot of population level surveillance systems on an ongoing basis, including the adult tobacco survey that I'm going to be speaking about today. Also the youth tobacco survey. We also have partners around the state conducting observational data collection at the tobacco retail level, looking specifically for point of sale data, how tobacco is advertised and marketed at the point of sale, and multiple other surveillance sources. We look at evaluation of our community programs and statewide grantees. We assess the impact of smoke-free air laws and other tobacco-related policies around the state. And in addition to looking at the impact, our team also just catalogs all of the tobacco-related policies and tracks policies statewide. So we're talking about like tobacco-free grounds policies at the school level, restorative measures for students caught using tobacco at the school level, hospital tobacco grounds policies, behavioral health system tobacco grounds policies, implementation of tobacco treatment in behavioral health systems and hospital systems. So a ton of data on policy. We also evaluate our 5-year cooperative agreement work plan with the CDC, do a lot of data management and analysis, and work on dissemination, getting the data out through fact sheets, infographics, slide sets, a number of different media. One thing that I didn't put on here was the evaluation of our Indiana Tobacco Quit Line, Quit Now Indiana. We manage Quit Now Indiana in our state office, and we run an annual evaluation of Quit Now Indiana participants. It's a follow-up survey to just kind of collect their feedback on their experience through the program, and also collect data on abstinence rates after going through Quit Now Indiana. So we also have a tobacco control strategic plan. It's a 5-year strategic plan, and I just put our mission, vision, and values up here. I also just wanted to mention down at the bottom, I'm not sure you can see that, but it provides a definition of commercial tobacco, which is really important and key to our work. So when we talk about commercial tobacco control, we're really talking about like tobacco that is manufactured by tobacco companies for recreational and habitual use. And we are not referring to tobacco that is used by indigenous communities for ceremonial and medicinal purposes. So wanted to make that really clear. So our work falls into 4 main priority areas: youth and young adults, prevention and treatment, prevention of exposure to secondhand smoke and secondhand aerosol now from e-cigarettes, tobacco treatment resources, and then the last bucket is just preserving our infrastructure with a focus on health equity throughout the state. So wanted to talk first about the Indiana Adult Tobacco Survey. So, this is similar to, some of you may be familiar with the behavioral risk factor surveillance system. That's also a key data source for us in commercial tobacco control. The Adult Tobacco Survey is also a random digit dial phone-based survey of adults in Indiana. So it's representative of the adult population in Indiana. We have about a sample of about 2,000 adults. It's a little different than the Burfess. And I just stuck this slide up here because I think it provides a good comparison of how the Adult Tobacco Survey lines up to our different surveillance systems in the state. So, going through adult tobacco, I think there's more there. Yeah. So current use of tobacco products, as you can see here, against recon covered adult smoking, looking at NISDA data and Burfess data. This is a slightly different data set. Survey is completely focused on tobacco use, secondhand smoke exposure, attitudes and beliefs about tobacco-related policies. So we have cigarettes at about 19% and e-cigarettes at about 12%. So those are the most popular tobacco products used among adults in Indiana. And then 35% of adults who currently use tobacco use multiple types, which we refer to as poly-tobacco use or co-use. Use of flavored tobacco products is just really popular in Indiana. And I'll say pretty definitively that if we were talking about youth in the state, flavored tobacco use is more prevalent among youth who use tobacco, even more than it is among adults. So we know this one tactic of tobacco companies and the tobacco industry is to flavor a number of tobacco products, including e-cigarettes, like candy, fruit, alcohol, and other appealing products to mask the flavor of tobacco. Wanted to mention, a huge disparity that we want to acknowledge in the state of Indiana and across the United States. And if anyone's following national news around commercial tobacco control, there's a huge push for the FDA Center for Tobacco Products to take action on banning menthol cigarettes specifically, because the African-American communities have shouldered much of the disease burden and death burden from menthol cigarette use, specifically with about 8 in 10 current African-American adults who use tobacco using menthol cigarettes, reporting the use of menthol cigarettes. So, really key to our work is talking about menthol cigarettes and talking about that health disparity. We also added, for about the last 3 survey cycles of the Adult Tobacco Survey, questions on marijuana use and cannabis use among Indiana adults. We get a lot of questions about how cannabis and marijuana kind of intersects with tobacco use and intersects with our work. And the truth is, we're seeing more and more that it's a product that is used interchangeably with nicotine through vaping, and of course combustion as well. So we are just beginning to foray into the cannabis landscape. We've started adding questions on prevalence on all of our surveillance systems and putting together some educational materials as well. But, a really interesting fact from the Adult Tobacco Survey is that 75% of adults who reported current marijuana use also report current tobacco use. So we know there's a huge issue of co-use among those 2 different types of products. We know that adults in Indiana who use tobacco really do want to quit tobacco. To the tune of 43%, almost half of those who use tobacco and who tried to quit tobacco in the past year did use some form of assistance, either through nicotine replacement therapy or prescription aids or the Indiana Tobacco Quit Line counseling services. And then, that's not really showing up. Oh, there we go. Okay. Among those, we asked about among those who visited a healthcare professional in the past year, what were some of the key outcomes related to tobacco cessation and, just at the base, like who was asked about their tobacco use. So among those who saw a health professional in the past year, the vast majority were asked if they use tobacco, which is really positive. That has actually gone up dramatically in the past 10 years. About 60% of those who use tobacco were advised to quit. We'd like to see that a little bit higher. 31% of those who use tobacco and were screened for tobacco use were referred to a resource to help counteract their nicotine addiction. And then about 30% as well were prescribed cessation medications directly from that healthcare provider. So we monitor these metrics specifically on an ongoing basis, and this really feeds into the work that we do statewide with hospital systems, healthcare providers, and behavioral health centers. Okay, and we also asked about awareness of the Indiana Tobacco Quit Line among those who use tobacco in the state, and we're pleased that it's around 70%, 7 in 10 of adults who use tobacco are aware of that resource that is free for anyone in the state who currently uses tobacco. We asked questions about secondhand smoke exposure and exposure to e-cigarette aerosol, and you can see some of the data here on the slides on exposure to secondhand smoke and aerosol in the past 7 days by setting, which is really interesting. So, the most common source of e-cigarette or secondhand smoke exposure is in the community. I think we've made great strides in Indiana, specifically with workplace protections at the state level and the county level. So just as an aside, we have a state law that was passed over 10 years ago that protects employees largely where they work, but it does have a pretty significant loophole in that it doesn't cover bars and it does not cover gaming or casinos. So employees who work in bars, taverns, casinos throughout the state remain unprotected by secondhand smoke. We do have a patchwork of local laws that do provide an additional layer of protection, but we'd really like to get to the point where there are no disparities in who's protected where they work, of course, because that is a significant limitation of the statewide law. So shifting gears, I'm going to talk a little bit about evaluation of our community partnerships. So just to level set and kind of lay the framework for the community partnerships that we're evaluating. There are 48 local coalition partners throughout the state, serving 38 of 92 counties. That does equate to approximately 75% of the population in the state. I will say that a significant limitation to our ability to cover the entire state is just simply we don't have the funding. We would love to get to the point where we're able to fund a local tobacco control coalition in all 92 counties and realize that that would make a really substantial difference, especially in rural communities that don't have adequate access to healthcare or resources to begin with. So just wanted to note that and note that this is a limitation in looking at how we evaluate partnerships because of some of the shifting of partnerships over time. We've been able to fund some counties for 2-year periods, 4-year periods, but not consistently over the last 10 years. So just poses some challenges when you're looking at evaluating our impact over time. So our community grants, all of their work is organized by those 4 priority areas that are outlined in our strategic plan. So you can see this table here. This is what really everyone who's doing commercial tobacco control work in the state is working on. We ask our partners to submit monthly program reports. I won't get into too much what that looks like, but in a nutshell, it's organized by those priority areas and then community indicators, how they organize their work. So we created this log form to help them organize and log their activities throughout the month. And then we open up an electronic survey and they input everything through that electronic survey on a monthly basis. Questions are here. And then From the data that we collect monthly, we generate a quarterly dashboard report that we share with our internal staff, that we share with our community partners, and that we share with other stakeholders throughout the state. I'll get to what our future plans are in some subsequent slides, but I just want to mention that we're working on building an interactive dashboard that we will put on our website, because something that we've wanted to do for years now is share the dashboard data with, just a larger group, with the general public. So we're finally allowed a platform to do that, and we'll be, the goal is to get that up and running in July. So quarterly dashboard report covers our activities from our community partners, lots of quitline data, policy data, and other inputs. And here are just, some examples of some data viz from the quarterly dashboard report. So this goes back to our community partners, and also goes back to our staff so that they can see the data, reflect on the data, and give feedback to our community partners, kind of have a sense of where the challenges exist to completing work that's written in their work plans, and provide a good level of technical assistance and feedback. This is just another example of what's in the dashboard report. Some of this information has been taken out because it identifies some of our community partners specifically. But just, the number of deliverables that they've been able to complete over the quarter. This information goes to our regional program staff. Our partners do also get deliverable completion reports. We really try not to give the impression that these are like report cards or meant to be punitive in any way. They're really just created to be a way to start a discussion between the regional directors and the community partners on what they might be facing, what challenges might be bubbling up in the community, and how we can help get past those challenges so that the work can get done. In addition, we provide a number of different tools and data viz to our community partners that they can then take and share with elected officials, with prospective coalition members, different stakeholders in their community. And this is just one example. So this is from Vanderburgh County, where Evansville is, down in the southwestern part of the state, and looking at outcomes over the past 2 years that we've gathered from not only their monthly program reports, but also looking at other sources of data that we gather and, dissect ourselves. So this is just one example. The other example is a county level data page that has a number of different commercial tobacco control related data points on the burden of tobacco at the county level, the economic impact, different chronic disease outcomes. So this is just another tool that we provide to our community partners as well. It's just really helpful when sharing with different stakeholders, sharing with potential partners, sharing with elected officials, talking about the benefit of their programs to their communities, and so forth. We also administer a partner feedback survey every 2 years. So we operate on 2-year grant cycles. And in the midpoint of the grant cycle, we send out an anonymous survey for our points of contact for our community grants to fill out. We ask a number of questions on how information is presented to community partners, how technical assistance and training are presented and received, what they feel like they're not getting from us, the challenges that they're having in their communities, lots of free responses, relationships with their lead agency that has taken on the grant. We find this to be like really, really helpful feedback, and we've used this feedback to make improvements and changes to our community partnerships over time, what the grant requirements look like, what our training plan looks like for the 2-year grant cycle, and so forth. So really, really helpful. We share this with our staff. We talk about it internally. And again, it's really provides a good opportunity to course correct and make some changes. Another piece that has been invaluable to us that we've added recently is focus groups for some of our coalition coordinators that are boots on the ground doing the work, to just, again, ask about how things are going, ask about the challenges that are faced, unique challenges in their community, how the work has changed over time. what they feel like they could benefit from that they're maybe not necessarily getting from us in terms of education, training, resources, tools, et cetera. So a really good, like about half of our total population of community-based coalition coordinators in the state were invited to participate and did participate. We got some really good feedback from that as well. So plan is to do this on a continual basis and probably expand the group that we're including as well. So that's our community partnerships and a little bit about how we evaluate those community partnerships. Shifting again, I want to talk about youth and young adult strategies. So when it comes to youth and young adult prevention and tobacco treatment resources, that has shifted and changed quite a bit with emerging products such as e-cigarettes in the last 10 years. And then, we're seeing the landscape shifting and changing even further with the introduction of nicotine pouches, synthetic nicotine, co-use of tobacco and marijuana, et cetera. So just some key factors contributing to youth tobacco use include what you see here. It comes down to tobacco industry marketing, which is incessant and relentless. The tobacco industry pours billions of dollars a year into marketing their products, largely to youth and young adults. The availability of cheap tobacco products, youth are price sensitive, and cheap tobacco products are appealing. Flavored products. So there are thousands of youth appealing flavors out there. We talked about that: cotton candy, watermelon, sour apple, et cetera. And then just gaps in regulation of these products. So flavored tobacco use among Hoosier youth. So I'm sharing 2018 data. I recognize it's a little dated and I don't want to get too ahead of myself, but this comes from the Indiana Youth Tobacco Survey. It is a school-based survey. We did go into schools in 2020, in the fall of 2020, and as you might imagine, that did not go well. So we did not get the response rate that we needed in order to share weighted data for 2020. And we just wrapped up the fielding of the 2022 Youth Tobacco Survey. We're working on the analysis, packaging it up, and it is embargoed by our agency. So more to come on 2022 Indiana Youth Tobacco Survey, and we're really excited to share the results. But flavored tobacco use is really common among youth who use tobacco products, as you can see here. And this is the picture just depicts an example of the availability of cheap and flavored tobacco products. So cigarillos, Swisher Sweets, 2 for 99 cents in a variety of flavors sold at convenience stores and other tobacco retailers throughout the state. So wanted to talk about, our main initiative when it comes to youth tobacco use, namely youth e-cigarette use, is Vape Free Indiana. It's a 3-pronged approach to addressing the youth vaping epidemic in the state. It formed in 2019 as a result of the 2018 exorbitant youth e-cigarette use rates that were measured through the Youth Tobacco Survey. So the 3 main areas of the initiative are prevention, public education, and tobacco treatment. And they align with commercial tobacco control best practices. And then underneath these 3 areas are some examples of the initiatives that we promote within these 3 categories, which I'll talk a little bit more about. I wanted to also mention a resource, being the Vape Free Schools Toolkit. This is available on the Vape Free Indiana website, and it has a really nice model tobacco-free schools policy that emphasizes restorative measures for youth who use tobacco. Really, really important. We see a lot of, the first line when youth are caught using tobacco in schools is suspension, and then it goes to expulsion. And, we're really not getting at the root cause of addiction, and we're not treating the addiction by sending youth home from school or suspending them, expelling them. So we're really emphasizing restorative measures and hoping that more school districts will adopt restorative measures to combat nicotine addiction. There's lots of prevention resources, information for parents and caregivers, lots of tobacco treatment resources, youth engagement stuff. So we have a youth empowerment movement, a youth-led empowerment movement in the state. It's called Voice. And so lots of information on Voice included as well in this toolkit. So really helpful resource on our Vape Free Indiana website. So wanted to mention the prevention resources that are included under the umbrella of Vape Free Indiana. A number of these. Sweet Deception is a peer-to-peer education program in which youth really share with other youth about flavors and debunk myths about e-cigarette use and vaping. Catch My Breath is an evidence-based youth e-cigarette prevention program accompanied by curriculum for adults as well. The Stanford Medicine Tobacco Prevention Toolkit is another theory-based, evidence-informed educational resource created by educators and researchers aimed at preventing middle school and high school e-cigarette use. And Vaping Know the Truth was formed in partnership with the Truth Initiative, the Kaiser Permanente, and American Heart Association. It's a national youth vaping prevention program. In terms of cessation resources or tobacco treatment resources for youth who are addicted to nicotine, Live Vape Free is a text-based stop vaping program for teens. Once enrolled, teens can access interactive content that is quick and easy to use, videos, quizzes, podcasts, etc. There's also This Is Quitting from the Truth Initiative. It's another text-based quitting program. And teen.smokefree.gov site is designed and run by the National Cancer Institute and also provides tobacco cessation information grounded in scientific evidence specifically for teens. So I know I just ran through that pretty quickly, but wanted to talk about youth prevention and cessation, really hoping that we can share 2022 Indiana Youth Tobacco Survey data in the coming months. We added a series of questions. We asked about marijuana and cannabis use in previous survey years, but in this survey year specifically, we added a number of questions about synthetic marijuana use, Delta products, mental health questions, family affluence. So really interested in looking at like how those social determinants of health weigh in on both tobacco use and cannabis use. So excited to share more about that. More to come, I promise. Just, wanted to mention some of our future plans when it comes to surveillance and evaluation. Right now, our team is working on looking at health outcomes in counties where we've had long-standing community coalitions. So in an effort to assess longer-term outcomes from that local tobacco control infrastructure, we're going to be looking at hospitalization data and some chronic disease outcomes associated with tobacco use and secondhand smoke exposure. So hope to share that in the next year or two. More focus groups, so really honing in on the qualitative data collection as well that has proven to be incredibly helpful to our work. We want to conduct focus groups again with all types of funded partners. We want to include coalition members and community stakeholders, so really widening that focus out to the community. And then it's not on here, but I really want to talk to individuals who use tobacco and let participants weigh in on what's working and what could change. And then just some final thoughts around surveillance and evaluation in this space, progress or success. And I think really this applies to any kind of community-based coalition or partnership work. Looks very different from community to community. Anita Gaylord was mentioned earlier by Rachel, my previous colleague who retired. She said, if you've seen one coalition, you've seen one coalition, and that's because communities throughout Indiana are vastly different, not only in demographic makeup, but also the resources that are available to them and who comes to the table. And so their needs are different. There are nuances that we need to obviously consider. So that's all part of it when we're looking at evaluating and looking at outcomes. process evaluation and outcomes-based evaluations are important, but outcomes measures are harder to generalize across communities for those reasons. Qualitative insights pair really, really well with quantitative data, and, you know, just giving you the opportunity to step back and listen to what people who are doing the work have to say, and just communicating regularly. We try to really focus on dissemination with every piece of data that we collect, because we understand how valuable the data are for the communities who are doing the work and needing to talk about their work and justify their work to decision makers. So, you know, we try to focus on different audiences. So obviously we talk often to our colleagues in public health and healthcare, but we try to generate fact sheets, talking points, infographics, social media graphics that can be used for a variety of different audiences as well, and really make the data approachable and easy to understand. So yeah, I think that's my last slide. I know it was like kind of like a hodgepodge of everything that we do in commercial tobacco control in the state. But I'm happy to take some questions. If anyone has any. Okay, well, thank you. Oh, I'm sorry.
It's not a question. I just wanted to let you know, I work closely with our person in Porter County. And I know you speak a lot too and work a lot with teens, but I work with the older adults. And so having that information from Quit Now has done wonders. I actually do have older adults that want to quit and appreciate having those resources at hand. And even the ones that don't smoke, we still provide them those materials to pass on to friends and family. So thank you for the work that you
That's
guys are
amazing
doing.
to hear. Thank you. Thank you for your work. And I'm glad you're connected with Carrie in Porter County. Yeah, thank you. Well, thank you all so much.
All right. Well, thank you very, very much for that wonderful presentation, Ms. Rupp. Now we are going to be getting to the end of our day here. But before that, I want to bring up Ms. Kelly Welker. Ms. Kelly Welker is the Director of Addiction Services at DMHA. So Ms. Welker, if you could please come to the stage.
Well, thank you, everybody. As you know, in the program, you may have seen Jeannie Bellman was supposed to do our closing, but unfortunately she had something come up and couldn't be here. So I'm kind of batting cleanup here on the fly. So I am Kelly Welker, as was introduced. I am the Director of Addiction with the Division of Mental Health and Addiction. And kind of breaking news, I'm excited to announce that as of this week, prevention has been added to my team as well. So very excited about that and can't wait to learn more and work with everybody. I would like to thank Syra Health and the SEOW committee for all their hard work on putting together the symposium and all the hard work they do throughout the year. I would also like to thank all of our wonderful speakers who gave great presentations and information, and everybody for coming and attending, and absolutely stay until like 4 o'clock on a Friday afternoon. So I appreciate that. Our work here at DMHA is aligned and guided by the principles identified by the governor of the state of Indiana. These key principles identified by the Indiana Commission to Combat Substance Use provide a framework of how the division's prevention plan will be executed in Indiana. The guiding principles are to be data-driven, comprehensive and holistic, and collaborative. The SEOW helps to fulfill the data-driven principle, and the identified behavioral health priorities guide the prevention strategic plan. We are grateful for all of our partners across the state who collaborate to collect substance use and mental health data. I would encourage everyone to visit the SEOW website to access the latest reports. In closing, I would encourage everyone to attend us at the inaugural Indiana Mental Health and Addiction Conference on June 27th and 28th, 2023 over at the Convention Center. Flyers with the QR code are on a table outside in the atrium, and I hope everybody can attend. And thank you all and have a wonderful weekend.